Then, the second part, the success factors of scaling up the Estonian sexual reproductive youth clinic network. So this is my work, efforts, and Venkarman Sandramoli and Team Rautse we have been together for the WHO. So why again? This is a case study, it's a sole case for WHO. Example in other countries on the success factors of scaling up the national program. A little bit of the methods. So we conducted literature review. We tried to find almost everything that has been published, reports. We did interviews of key stakeholders, persons who were involved in the process in the beginning, policy makers, ESHA-personnel, Estonian health insurance fund. And then, of course, part of this is based on our knowledge of the problem, because we have also learned many things during the years that we've been involved. And then at the end, we analyzed the scale by using WHO expanded framework. What is that? It is a theoretical framework. It is a step-by-step approach for designing, implementation, and assessment of results of scaling up health interventions. So it is a kind of structural way of looking at how healthcare programs have been scaled up. So instead of looking at the program in a chronological way, we did this, then we did this. It's kind of helicopter view. You look a little bit further, and that teases out different kind of factors that we thought would have been influenced by Estonia. So this is our opinion. You can disagree, but this is from our external eyes. So first, we documented the scale from 91 till 2030. And we made this kind of fancy graph. I think this is a repetition of Ella's presentation. But below we have the number of clinics. What do we have here? Okay, independence. The first grassroots initiatives. ESHA was founded to scale up starts. First internet counseling. Estonian health insurance fund was founded. The legislation changed. On the top, it's about the environment. The top line is for adolescent sexual reproductive health indicators. Then there's the heat epidemic 2001-2, and then there's the improvement of the outcomes. Then the middle section is about funding. In the beginning, the program struggled with the short-term financing, but then 2002 forward, there was a structural, national, sustainable funding. Then, after the documentation, then we started to analyze why it was successful. In our view, it's the sum of many factors, and even if one of the factors would drop out, the scale-up might not have happened, or the scale-up would have been less successful. So here's our list. The environment. Estonia had a favorable social and political climate for offering youth-friendly sexual reproductive services in the 1990s. Unlike in many other countries, there was only moderate, moral, religious, or political opposition. That comes to the point that Everett earlier said maybe in other countries this would not happen. So this was one of the reasons. Second, there was a need. The need for the adolescent sexual reproductive services was clearly demonstrated. There was some new data that showed that the adolescents' sexual and reproductive health indicators or outcomes were poor. And in response to this, the successful Swedish model of delivering youth-friendly services in specialized youth clinics was adopted. Then, third, there's a national professional organization that coordinates and represents the youth centers. And yeah, well, I think you all know this, but let's run the task. What ESHA does: coordination, monitoring of the youth clinics, development and implementation of the quality standards, continuous training, representation and lobbying for political commitment and funding, and also becoming a credible partner of the Ministry of Social Affairs and also the service. Of course, we should not forget the crucial importance of the personnel who were involved. So the enthusiasm and dedication of ESHAs and also the youth clinics personnel was crucial for transforming the first grassroots initiatives to a national program. There was also substantial international assistance for the program and ESHA in the beginning. A number of international organizations, I think these were also mentioned in the beginning. IPPF, World Health Organization, World Bank, SIDA, Global Fund. So they offered trainings, practical and financial assistance, service models, opportunities for networking, cooperation, and so forth. So this has been also important. Youth clinics themselves, or say healthcare providers, the need for the adolescent services was also recognized by user organizations, youth clinics, and the healthcare providers who started to provide the services. So there was no resistance rolling out or implementing the services. Advocacy, personnel of ESHA and youth clinics played an important active role in advocating and promoting youth-friendly sexual and reproductive health services to policymakers and also to the medical professionals. This is a little bit sidestep from the study, but I wanted to add a couple of slides on the changes in the advocacy. The environment has changed, the program has been scaled up, the outcomes have improved, there's funding. So the question what I have is that has the advocacy role of ESHA changed? And I think it has. If we, again, one of my graphs, if we put this through the lens of advocacy, the early years, these are the blue bars are the number of youth clinics in the education. If we look at the advocacy here, early 1990s, there was a problem and there was an urgent need to do something about it. So then the advocacy, it's clear and it is easier to be more convincing. Then, if we, on the other hand, then the program was scaled up, things stabilized, it will say the last 5 years, there's kind of stagnation of the program. Actually, the stagnation is the wrong word, but the saturation of the service. So, things have stabilized, things are going well. And in this environment, at least in my eyes, the role, the advocacy role of ESHA has changed. It is, I mean, this is by no means discredit for the first wave, but I mean, in this environment it's more difficult to advocate. When things are going well, it is difficult to have a convincing advocacy message. And I think this will be one of the main challenges. Because we don't want to come in 5-10 years' time to make a case study of the country where the graph went like this. So that, I think that will be the challenge for the ESHA in the future. So let's maintain the good situation. Then also important, sustainable funding. So the first years there was a project-based financing, and then 2002, Estonian Health Insurance Fund started to finance the youth clinics. I mean, and that did not change automatically. There needed to be a legislation change that enabled the health insurance fund to start the clinics. Then, last point, there is no success if it's not recognized. And the adolescent sexual reproductive health outcome slides have shown the outcomes have improved remarkably since from 2001 forward, but measuring it would have not been possible without developing good reporting and monitoring systems. And also that the youth clinic network, the clinics, they were developed at the same time with the school program. And together, these two interventions have most likely contributed to the improvements. Again, this is the same point on the control group and so forth. There have been many studies and international publications on Estonia. And the success of the Estonian Youth Clinic Network has been nationally and internationally recognized. And I would like to congratulate ESHA for the good work and inviting us here today. Thank you.
Jaa, no kui on 20. sünnipäev